Hello, I'm Dr. Michael Fossel. Thanks for joining me on this. We're going to talk about age-related dementias and the prospects for intervention, specifically prospects for being able to cure and prevent age-related dementias. I think that most of you are like me in many respects, which is that you've been frustrated by age-related dementias, for example, Alzheimer's and Parkinson's, because they were difficult tasks in terms of finding a cure or anything that's an effective intervention. In fact, to look at it a slightly different way, let me give you a quote from an industry publication. This is Fierce Biotech. And this is quite true, that Alzheimer's is a huge opportunity for the industry. But the failure rate has, they say here, run about 99%. Truth is, most of us would say the failure rate's been 100%. And so it's certainly been a frustrating disease for all of us. This is something I have been interested in for about 45 years. In fact, since I was a student on this campus, which is Stanford. My first interest was in aging itself, but I began to be more interested also in the dementias and specifically Alzheimer's. In fact, my background was the development of the nervous system, which is quite interesting. But I also noticed that when we talked about aging, most people would simply say it happens. There's nothing to it. It just occurs. It just wear and tear, what do you expect? Rather than ask themselves, what are the mechanisms involved in age-related disease in general, and the dementias more particularly, and especially Alzheimer's disease. So this has been something that has intrigued me for a long time. And in fact, I've published on it in many respects. First publications I put out were these two papers in the Journal of American Medical Association a little more than 20 years ago. And they were, in fact, the first papers ever in the medical literature to suggest that if we could truly understand the aging process at a fundamental genetic and cellular level, we probably could intervene effectively in age-related diseases. And now this was followed by a textbook with Oxford University Press, which is very academic, not easy to read, some 4,700 references as I recall. But what I did was I went through each and every organ system and cellular system in the body looking at age-related diseases and asked, how do they truly occur? What do we know about them? What do we currently have in the way of potential interventions or actual interventions? And then potentially, what could we do if we understood a little more about the aging process at a more fundamental level? And that also culminated in this other book, came out a few years ago, that I was invited to write, and that the Wall Street Journal praised as one of the best science books of the year. So that was for the general public, but the textbook is available as well, and it is a very extensive look at all of this. Now, I also gave the first talk ever at this. This is the National Institutes of Health in Bethesda, and that was 25 years ago this week. And what I said in that talk was the same as I said in the Journal of American Medical Association articles. I said that if we could truly understand the aging process at the genetic and cellular level, we would be able to intervene in age-related diseases, which has never occurred before in human history, but it takes a full understanding of that process. I also stated that anyone who thought that you could reverse aging at the cellular level was naive. But likewise, anyone who felt that you could not reverse aging at the fundamental level was naive. The question was, can we or not? Where is the data? And that remains true today. And I'll show you some of the data since that lecture 25 years ago. But it's still true that what we need is not simply good theory, but good data as well. But regarding our overall look at these kind of diseases, let me point out that in many clinical syndromes, and I'll give you examples of this in a minute, we are faced with clinical syndromes that appear to be slightly different. So we have clinical presentation A or B or C. But when we look more carefully, we discover that they share certain fundamental parts of the disease, certain fundamental processes that are expressed in different ways. But when we look more carefully, we realize there is a fundamental shared part of the disease that drives the process. Here's an example of that, and this is bubonic plague. I think many of us are aware that there are at least three major presentations of plague, which is bubonic plague, pneumonic plague, and septicemic plague. But they all share a common underlying etiology, that is, the infection is Yersinia pestis. And the reason you see bubonic versus pneumonic versus septicemic has to do with the point of entry and various host-related factors, rather than having different microbiological etiologies. So they're all one infection, but we see not only these three different presentations, but there's often an overlap. Some patients with bubonic plague will have pneumonic symptoms and so on, as well as having other slightly different approaches or different presentations. So this is fairly common, but the same sort of thing goes on independent of the microbiological venue. If we look at things like age-related dementias. So, for example, I think all of us are aware of these typical syndromes clinically in neurology, which is Alzheimer's disease, Parkinson's disease, frontotemporal dementia, and vascular dementia. And yet, while there's a certain amount of validity to these clinical syndromes, we also recognize that there's overlap. So, for example, some of my Alzheimer's patients will have motor deficits. Some of the Parkinson's patients will have cognitive deficits, for example, memory or executive function. And when we look at the pathology postmortem, you see that many of these patients also have vascular dementia components. So it's become clear to us that while there are really syndromes that we're dealing with, there is a certain amount of overlap or fuzziness about the edges in some of these patients. And this is even more true when we look at the full alphabet soup. So whether we're looking at posterior cerebral atrophy or Huntington's dementia, a number of these diseases appear to have a certain amount of overlap with some of the other age-related dementias. So we typically think of them as mixed dementias because some patients will have aspects of both of these things. And again, there really are patients with Alzheimer's or Parkinson's, but some patients will have some overlap. There have also been atypical syndromes where patients don't fit neatly into any of these categories, but have aspects of several of the categories, sometimes prompting a new part of the alphabet soup. So over the past decade or so, you've seen actual clinical conferences and professional interest groups devoted to, for example, mixed dementias or atypical dementias. But there's also been a growing consensus that there's something going on at a more fundamental level. That all of these age-related neurodegenerative diseases in humans share something, some deeper fundamental constant that is expressed in different ways in different patients because they start with different genetic and epigenetic backgrounds, but there's something that they share in common. And we'll come back to what that is. But about 2 years ago, with this sort of framework in mind, the Alzheimer's Association paid me to go to Washington for a conference that I was helping to organize on animal models in dementias, and specifically Alzheimer's. And the message really of this conference was this one. All of us know that, quote, everything works in mice, but nothing works in humans. Now, the reality is not everything works in mice. And in fact, the same can be said whether we're looking at baboons, rhesus monkeys, dogs, cats, or other rodents. It's not just mice. But in general, what you find is that in many of these animal studies and animal models, you'll see intriguing results, some outcomes that are very tantalizing, but that simply do not translate well into human trials. So the bottle is essentially empty. And the question is why? And what I pointed out was that partly it derives from some non-shared genes. For example, mice and humans share about 75% of protein expressing genes, but that's 25% they don't. And if you're investigating a model that relies on pathways in that other 25%, you can expect poor translation. But I said that there was something more than that too, because while we have very remarkable technical abilities, for example, monoclonal antibodies, or targets, for example, beta amyloid plaque, what we lack is an overarching model to explain how these diseases work, specifically a unified systems model. So the major problem, as I view it, is that we've been digging in the wrong place. And whether you're digging at beta amyloid, tau tangles, inflammatory changes, calcium channels, mitochondrial dysfunction, lymphatic dysfunction, we have been disappointed because we're not looking at this deeply enough. And if that's true, then digging deeper doesn't help. And this is true also with regard to the kind of resources we put into this. So, for example, Biogen Eisai, as of about a year and a half ago, had put $750 million into this. The NIH budget is enormous for this sort of thing. The number of PhDs and MDs we put into this is enormous. The sheer work effort and hours put into this, the technical training involved, all of these involve a massive machine in a sense like this. This is one of the actual biggest excavators in the world. But it doesn't matter how big the excavator is if it's digging in the wrong place. I think of the old Indiana Jones from the first movie, where he and Sala suddenly realized that everyone who's been digging is digging in the wrong place. Well, again, it doesn't matter how hard you dig, how much money you put into it. If you're digging in the wrong place, you're not going to get the answer. And I suggested that that was our problem. What we needed was an overarching model that explained where the right place to dig was. Well, this is what I said we needed. We needed a unified model, we needed a systems model, and we needed a novel and feasible point of intervention. By a unified model, I'll get into more detail, but it had to explain what we see in age-related human diseases in the CNS. Also, age-related animal dysfunction, because you see behavioral decline in animals as well, As a systems model, it needed to explain how the upstream risk factors resulted in CNS neurodegeneration, and it needed to explain the gamut of downstream pathology. Why do some patients have more in the way of beta amyloid plaque than others? Many patients have tau tangles. What about the mitochondrial dysfunction? Why do we see variety at all? And finally, as I said, we need a point of intervention. We need to know where to dig, and we need one that we're capable of going after. So as a result of that talk, I was actually mobbed by people who congratulated me, who agreed that what we needed was a model. And one gentleman asked me if I actually had such a model. I said I did, but I saw no reason to impose it upon other people. I simply wanted to point out that we need to dig a little deeper, or look for the right places to dig. It's a better way to put it. And it turned out, he asked me if I did have such a model, which I did, would I publish it? And he turns out to be the editor-in-chief of Alzheimer's Dementia, who invited me to write this paper. Well, it went through 8 reviewers, all of whom were complimentary, who asked me to write more. So it turned into a very long paper. I'm told that it reads a lot better with a glass of wine, by the way. But essentially what I was trying to do is propose such a model that was consistent with the known clinical data. It was predictably valid in explaining the anakinumab and solanezumab data and so on, and also offered, as I say, a novel and effective point or feasible point of intervention. So that's what this did. Now, when I say the unified model, again, I'm talking about the heterogeneity within dementias. So, for example, why is it that some patients get Alzheimer's literally at age 25, others never, or at age 70? Why is it that some patients with ApoE4 have an increased risk, but others don't actually get Alzheimer's? And if so, why does this occur? Likewise, why is it that head trauma appears to play a role? But there's this heterogeneity within the dementia. Whether you're looking at Alzheimer's, some people have more in the way of executive function dysfunction, some people more memory loss. Likewise, for Parkinson's, you'll see some variety in the clinical symptom. So why is that? Also, heterogeneity between dementias. We know that there's this whole cadre of age-related neurodegenerative diseases, but why does my patient here get Alzheimer's, my patient here gets Parkinson's, and this one over here gets frontotemporal dementia? Why is it there are these differences in who gets what? Also, the heterogeneity between species. If we look at almost any, for example, mammal that we look at, we see these declines in behavioral function, but they're different than humans, and the histology is slightly different. For example, in mice, you may see less of beta amyloid, and other animals, you may see more of something else. So why does it differ between species? Can we explain that as well? A unified model. Also, as I say, a systems model. If we talk about upstream mechanisms, for example, genetic mechanisms, or a history of trauma or infections or exposure to toxins, why do a number of these things increase your risk? That is, how does that translate from something that occurred, exposure to paraquat or dioxin, or exposure to, or a history of head trauma, or a history of 2 ApoE4 alleles or presenilin gene? How does that translate into increased risk of Alzheimer's or Parkinson's? And likewise, the downstream biomarkers. We know that some patients have more or less in the way of beta amyloid or tau tangles, or different clinical outcomes. But how do we get from the upstream mechanisms or upstream risk factors to the downstream biomarkers, whether they're clinical or laboratory? So we need a systems model that invokes all of this. And that's really what we need to look at. With regard to it being unified, as I say, it's got to explain different age-related clinical syndromes and other age-related dementias, as well as encompassing the animal models. And when I say systems, it's got to understand what that shared fundamental etiology is, how it is expressed in different ways with the various risk factors. Why do we see these multiple intermediate pathways in terms of the pathology and different clinical outcomes? So the way that I look at it is that what they share as a commonality, a fundamental commonality, is cell aging, which is related to aging in general, but it's a little more complicated than that. So we have one fundamental process, for example, glial cell aging, with multiple pathways depending on your genetic and epigenetic background. As an example of this, we have patients who have some 2 ApoE4 alleles or 2 ApoE2 alleles or an ApoE2 and 3 allele. Likewise, epigenetic baselines in terms of exposure, paraquat, dioxin, head trauma, infections, radiation, and so forth. All of these represent different risk factors that are translated from cell aging downstream to various outcomes we can measure, and finally down to neuronal dysfunction and a clinical disease, for example, in dementia. As one example, let's take Alzheimer's. We can look at some of the risk factors there. As I say, head trauma, a number of genetic risk factors, certain exposure to certain toxic agents. And what we see is in these patients, you tend to see beta amyloid plaque and more specifically tau protein, tau tangles. And the outcome is you get dysfunctional neurons, and the outcome of that is the clinical syndrome, which is Alzheimer's. Whereas in other patients with slightly different risk factors, for example, exposure to paraquat might be one, and different genetic backgrounds, we see the expression go through a different intermediate pathway, which is alpha-synuclein, and the changes that occur in substantia nigra and so forth. And the outcome of that, again, is still neuronal dysfunction, although anatomically a different location. And the outcome clinically is Parkinson's disease. And if we compare different animals, you still see fundamental cell aging. But for example, the murine genetic baseline is different. As I noted before, we share about 75% of the protein expressing genes, but we don't share that other 25%, let alone some of the regulatory components. So the outcome is different pathology, different histology, different behavioral outcome. And yet they share still a fundamental etiology, which is cellular aging changes that come out as behavioral changes. And this is true of different species. So the question, though, is what does this have to do with where we can effectively intervene? And the answer is this is sort of a quick overview, conceptual map of where we stand with regard to effective interventions for the dementias. We have a number of synaptic drugs, usually about 6 is the list, including things like Aricept, that have no effect on neurons per se, neuron survival. They have an effect on synaptic function or synaptic efficacy. And the result is we get some symptomatic change, perhaps, but no change in the actual vector of the disease course, for example, in Alzheimer's disease. We also have a number of approaches, and I give the example of monoclonal antibodies here, and aducanumab is one example, where we're aiming at a specific pathway. In this case, we're aiming at beta amyloid, not aiming, by the way, at dozens of other pathways like tau tangles and mitochondrial dysfunction and microglial activation and so on. And the outcome, again, is we're treating a downstream result in only one of the various intermediate pathways, in this case, beta amyloid. And so the outcome, again, is disappointing. And my suggestion is if we want an effective and feasible point of intervention, it should be cell aging itself, that is, treating the common fundamental pathway that underlies age-related neurodegenerative diseases. So I've talked a little bit about the unified model and the systems model and why it's important, but I'd like to, for a moment, get into this aspect of systems model because it's one that most of us don't quite get. We still focus much too narrowly on things like beta amyloid and tau tangles without understanding it in a systemic point of view. In short, we're looking at the trees, not the forest. So let me start with an analogy from, in this case, engineering. This is the cockpit of an Airbus 380. In the upper right, you're looking at a Rolls-Royce Pro 15 jet engine. In the lower right, you're looking at a Trent 900 turbofan, which powers the Rolls-Royce jet engine, and one of its fan blades. Well, a friend of mine was involved globally in the design of some of the turbofan and the Rolls-Royce jet engine. And he commented to me that the model I have for Alzheimer's and other age-related dementias was a systems model. And I asked what he meant by that, suspecting he may have been right, but wanting to understand it. And he put it this way. He said, let's say that fan blade fails, it occasionally happens, in that Trent 900 turbofan. I don't ask, he said to me, I don't ask what's wrong with the turbofan blade. I ask what's wrong with the turbofan blade in the turbofan engine, in the Pro 15 Rolls-Royce jet engine, in that Airbus 380 at 35,000 feet going 100 miles an hour at a high RPM and high temperature. In short, it's a systems issue, not a component issue. It's not simply an individual component like beta amyloid. The question is, where does it fit in the complex physiology of the human brain? So too narrowly do we focus sometimes on a component without looking at the entire system and asking how it works. Granted, it's more complicated, but you're not going to understand that entire plane and its function by simply laying all the parts out. You need to see how they work together dynamically. The same is true medically. So, for example, if we knew nothing about the microbiology of, in this case, a COVID-19 infection, and what we knew about were these list of signs and symptoms, it doesn't matter how carefully we measure the signs and symptoms, how accurately we measure, for example, nasal congestion or fevers and chills and so on. What we need to do is not measure them, but understand how they fit together in the context of a viral infection, the interaction with your immune system, and a number of other organs of the body. A COVID-19 infection is not a set of components. It is a dynamic process. It is a system. The same is true of this. This is a river that all of you have heard of. Probably none of you have been to. It's a river in the Congo called the Ebola River. which is what the Ebola virus was named after. And what you're seeing here is a list of 9 common signs and symptoms. I didn't include fatality for an Ebola infection. But again, I don't care how carefully you measure, for example, the bleeding diathesis in a patient with Ebola. That is not the same as understanding the disease. And if we're going to treat the disease, it's not enough to ask ourselves which blood product should we use, plasma, whole red cells, particular components for bleeding. What we need to do is understand the disease itself. In this case, again, a viral infection and its interaction with the human immune system and a number of individual cell types. So it is a dynamic system. It is not a matter of components. The same is true when we look at aging and age-related diseases. These are common findings that we see at the macroscopic level for aging. For example, the glomerular filtration rate decreases with age, and we have formulas for it, a number of formulas actually. Vascular pruning, poor healing. These are things we see at the macroscopic level in ourselves, in the mirror, in our patients, out in public, but they are not aging. They are components of aging, or biomarkers, hallmarks, or downstream outcomes of aging, but they're not the aging process. If we want to understand the aging process, it is not enough to simply measure accurately and excruciatingly good detail how the glomerular filtration rate goes down. We need to understand why it goes down, what's going on at a deeper level. The same is true at the microscopic level. These are microscopic biomarkers, if you will, of aging, but none of these are aging. The declining rate of the decreasing efficiency of ATP production compared to reactive oxygen species, that ratio, the declining DNA repair, telomere shortening, acetylation changes, methylation changes. I don't care how accurately these are measured, they are not aging. They are biomarkers of aging. They're hallmarks, they're components of aging, but they're not the systemic process. They're not the dynamic process, and that's what we need to understand. And if we look at the dementias, the same thing occurs. It doesn't matter how good you are at measuring the histology of beta amyloid plaque deposition, or alpha-synuclein, or blood-brain barrier failure, or changes in the lymphatic system. These are important components, but they are not the systemic process that is involved in age-related neurodegenerative changes. There's where we need to go. The same is true if we delve down deeper and look at genetic changes. We know, for example, that 2 ApoE4 alleles increase your risk of Alzheimer's, but why? We know that having 2 ApoE2 alleles lowers your risk of Alzheimer's, but why? What's the dynamic process that results of that? Likewise, we've got more than 200 other genes that have been linked to increase, or in some cases, decrease risk of various dementias. But the question is not, can we identify the genes and their specific function, but can we tell what that gene and that function have to do with dementia? How does it translate into increased risk in a dynamic sense, taking into account everything else that's going on with a patient's histology and physiology? So as Einstein said, any fool can know. The point is to understand. It is not simply a matter of knowing all the genes involved. It's a matter of understanding how they work. And I'll give a couple of other examples of this a little later on, particularly with regard to the genes. We need to understand what they do and how they do it in context dynamically as a system. In other words, how can we understand aging and age-related diseases? Because we can't cure these diseases unless we truly understand the age-related underpinnings. So let me introduce you to a friend of mine. This is Dr. Leonard Hayflick, and Len and I have been in contact for decades now. And he, some 60 years ago this year, actually, was the first person to describe cell aging. And in a discussion he and I were having about a year ago, in fact, I quoted him in that paper I put out, he gave me this quote, and he is correct. All of us would agree that the single best predictive risk factor for age-related disease is aging, but we then entirely ignore aging as a process, and we focus in on other downstream things. For example, if I can know one thing about you, and it could be your genes, it could be your history of head trauma, it could be any number of things, but I only need one particular data point and want to predict whether you are likely to have Alzheimer's, the best data point that I need is your age, because 5-year-olds tend not to get it, and 95-year-olds tend to get it. And in fact, knowing your age is a better predictor than almost any gene or other environmental factor I can think of. And yet, we tend to ignore that and again, focus in on beta amyloid or tau tangles without asking ourselves, how does aging play a role in this, which is critical. So let's look at aging for a minute. These are a number of species that most of you are aware of. Human beings, for example, have a mean lifespan now about 75 years globally. That is Coco, a gorilla. She died at about age 40. I was actually her babysitter for a year, for 6 hours every Wednesday. I am embarrassed to admit she had a bigger sign language vocabulary than I did, and that's her little cat Allball. And then if you look at domestic animals, typically they live about 15, 20 years, depending on the breed. Likewise, if you look at laboratory rodents, you're typically looking at 2 or 3 years, again, depending on the breed. Well, why do these animals have different lifespans? We know part of the answer, but it's not the answer. We know, as I said before, that mouse and I share about 75% of protein expressing genes, but that's 25% we don't, and that's not even accounting for the regulatory genes. So we suspect that has something to do with genes, as with the other species seen here, or any other species you'd like. All of these species, by the way, have bitten me at one time or another. But the question is not, are they genetically different, but how do we go from genes to different rates of aging? And the same thing is true even within the human species if we look at genes. So as an example, there's a group of about 30 progeric children. And about 20 years ago, I would gather them together from all over the world, along with Bill Sample in the background with his hands up here. And here we're in front of the White House, the North Portico. Well, these children die overwhelmingly of age-related diseases. They are all bald. The ones you see with hair are actually wearing wigs. They have thin skin that doesn't heal well. They have osteoporosis, osteoarthritis, and they tend to die overwhelmingly of age-related vascular disease. For example, there's a child in the back row here on the right who at age 7, a few months from now, ended up having a massive heart attack in the backyard while throwing a baseball with his father. Why do these children die young? Well, we know a gene involved. It's the lamin gene. But while we've identified the gene and the correlation, we don't know why that results in such rapid aging in these children. Now, these children are kind of fun. I have to tell you that the two in the front row, that's Sammy with the red baseball cap and Ori with the orange Hawaiian shirt. Actually, we had just come in out of the White House. They were actually sitting there on the steps just inside the North Portico door on the left. Those are the stairs to the presidential quarters, private. And it turns out that underneath those 3 children, there is a pressure sensor switch. I didn't tell you. When you do that, the Secret Service will do what they did for us, which is to very politely but quite firmly escort us out the North Portico door. So don't try going up those steps. But it is true then that aging is not a matter simply of genes, unless we understand what the genes do, but nor is aging universal. For example, every cell in your body right now derives from a fertilized ovum that you got from your mother, you got from her mother, you got from her mother, and that goes back about 3.5 billion years of the germ cell line. And during that 3.5 billion years, although the genes changed a lot, there was no cell aging involved in those cells. And yet many of the cells, somatic cells in your body right now, show age-related changes. Now, many people would ascribe aging to mitochondrial dysfunction, but there you run into the same problem. Every mitochondria in your body, you inherited from your mother, and that maternal line goes back about 1.7 billion years, depending on who's doing the estimate. And during that time, there was no evidence of mitochondrial dysfunction or aging at any time. And yet, in a matter of decades, if I were to measure your mitochondrial function in most of your somatic cells, I'd see age-related changes. So we know that aging does not occur in some contexts and does occur in others. The question is, why is that? Well, to use an analogy from the literature, it actually has to do with entropy and maintenance. And most of us would say that entropy plays a role in this wear and tear. And I think that's accurate. But in the germ cell line, what you find is it's balanced against flawless maintenance. So the outcome is you don't see aging. Whereas if you look at the cells in that 80-year-old man's hand on the left in the wheelchair feeding the bluebird, if I look at any of the cells, the fibroblasts, keratinocytes, the vascular endothelial cells, melanocytes, almost any of the cells I look at, I'll see age-related changes, not because they've had more entropy in the germ cell line, but because maintenance has failed. Maintenance needs to be absolutely flawless to maintain itself in the face of entropy. I sometimes think of this as red queen theory. Now, red queen theory classically is applied to predator-prey evolutionary change over time, but it also applies here. What we're really saying is that for cells to maintain themselves, they need to run as fast as they can just to stay in one place. They're continually being dragged down, as it were, by wear and tear or entropy, but maintenance is what allows them to run as fast as they can and stay as effective cells. And what happens as maintenance fails is this. What you find is that as telomeres shorten, you see an altered pattern of gene expression, and you begin to see the molecular turnover changes. Now, in young cells, what you find is they run, as it were, very fast to stay in one place. And this is true whether we're looking at microglial cells, which we'll look at in a minute, or whether we're looking at some of the cells in my epidermis. What you find is that any molecular pool, again, whether it's collagen or elastin in my skin or beta amyloid out between my microglia and my neurons, or some of the changes in the molecular pools of chondrocytes in my knees, In young cells, in young organs, what you find is the turnover is very rapid. So, for example, you are making collagen, you are breaking it down, you are making it, breaking it down. It's entirely being recycled. Whereas in older cells, this process slows down. In young cells, when there's damage to a molecule, it tends to get washed out because the molecule is replaced. Whereas as cells get older, you find that the rate of turnover, molecular turnover, recycling, if you will, also slows. So you find that there's less and less of this turnover, and the outcome is you begin to get an accrual of damage. And maybe a nice domestic analogy might be this. In a young cell, it's like having a house where you clean it once a day and the house always looks very neat. Whereas an old cell like this one, what you're doing is you're cleaning house once a year. Now, the amount of wear and tear is the same. The amount of dirt that gets generated in terms of, for example, hair and dander and so on in the house is very similar. But if you're only cleaning it once a year, there's an accrual of damage that does not occur in young cells where it's being cleaned, as it were, once a day. In fact, you can actually look at this mathematically. This is taken from my textbook. What you're seeing is that in young cells, where the turnover is very rapid per any unit time you pick, the damage accrual rate is very small, whereas in older cells, where the turnover rate is slower per unit time, you get a higher accrual of damage. So that's what's going on at the fundamental level. Now, how does this apply to central nervous system neurodegenerative disease as we age? Let me look at an example of this. We could look at any number of cell functions, but we've got fairly good measurements when we're looking at beta amyloid turnover. We know, for example, that the microglial cells will make beta amyloid, will secrete it, they will then rebind it, bring it back inside the cell, degrade it, make it again, secrete it, bind it, bring it back in the cell, and that turnover is continual. But in young cells, it's very rapid. So anytime you have cross-linking, for example, of beta amyloid molecules, it doesn't tend to stay very long before those microaggregates get broken down. Whereas if we get a little older, we find the rate of turnover goes down, so the microaggregates tend to increase out between the neurons and the microglia. And you might reasonably enough ask, what does this have to do, for example, with genetic risk? For example, if I have two ApoE2 alleles, I know my risk of getting Alzheimer's is much lower than if I have two ApoE4 alleles. But people with two ApoE2 alleles tend to make amyloid molecules that are not very sticky. So you don't tend to get much in the way of microaggregates. So even as the turnover slows down with microglia recycling of amyloid molecules, you find that there's not much in the way of beta amyloid microaggregates. So ApoE2 patients, double allele ApoE2 patients, tend not to get Alzheimer's, particularly at a young age. Whereas if they have two ApoE4 alleles, what you find is the molecules typically being made by the patient are stickier. So at any given rate of recycling, you'll tend to get more in the way of beta amyloid microaggregates than you would with a patient with lower risk ApoE2 alleles. So that's why these patients tend to get have a higher risk of getting Alzheimer's and tend to get it at a younger age. It has to do with the molecules, but it's all in the setting of cell turnover or molecular turnover and cell aging. And in fact, regardless of what you have for ApoE alleles, you find that you begin to get beta amyloid plaques over time, the older you get. And again, depends on your genetic background, but the constant shared fundamental underlying process here is that of cell aging and the change in molecular turnover. Nor is it simply a matter of beta amyloid. The same thing is true whether we're looking at tau tangles, there's a classic reference, mitochondrial dysfunction, inflammatory changes, and so on. And the result of that clinically is this: synaptic loss, cell dysfunction, loss of actual neurons, and clinically what we see is various dementias depending on the genetic and epigenetic background. So again, the question then is, how fast do you run and what controls how fast you run? And there the answer has to do with this. You have a number of upstream risk factors that affect the rate of cell division. For example, your age in general, over time, what's happened to you, exposure to toxins, chemotherapy, head trauma, which will increase the risk of cell replacement as cells get damaged, hypertension, hyperglycemia, which will increase your risk of vascular cell turnover and therefore vascular dementias. And radiation exposure, a number of infectious agents can increase your rate of cell turnover. And as cells divide, telomeres shorten, that changes the pattern of gene expression, molecular turnover slows down, and we see what we just alluded to, which is gradual increase in cell failure or cell death. And the outcome downstream is what we measure, which is beta amyloid plaques, tau tangles, a lower ATP to ROS ratio, and so forth. These are the kind of things we see downstream. And what we notice is that when we try to intervene upstream, for example, if we make sure you're euglycemic, and we make sure you're normotensive, we can lower your risk of vascular dementias. But we can't totally prevent it, and we certainly can't reverse it. And the same is true of decreasing your risk of head trauma or other things. All of these are important things to keep an eye on, but they don't offer us a way to reverse the process. And certainly we've tried. As I mentioned, we've had more than 1,100 interventional trials, which have so far failed to demonstrate any effective intervention for these dementias. And the same is true when we look at things like beta amyloid plaque and some of the classic monoclonal antibody studies. None of these have been able to show that we could actually stop, let alone reverse the disease. So the effective point of intervention really is cell aging itself. In this case, the shortened telomeres and the altered pattern of gene expression. And the question then becomes, would it work? Is it feasible? Well, there have been a number of reasons for us to think that. The first time that anyone ever demonstrated reversal of cell aging in human cells was 23 years ago in a classic paper by Andrea Bodnar in Science. And what they showed in the group out in California is that if you use telomerase, you can reset the actual epigenetic pattern and result in essentially normal young cells. The same is true if we look at skin aging in the classic paper by Walter Funk in Experimental Cell Research 21 years ago. You can actually grow young human skin from old human skin. You can do the same thing for osteocytes, for vascular endothelial cells, taking old coronary artery tissue to grow young coronary arteries. And the first paper ever that looked at this in terms of animal data was 2011 in a paper by Rhonda Pino at Harvard. But he used a change in the germ cell line, whereas this paper of De Jesus et al. With Maria Blasco's group in Madrid did something using an AAV9 vector and a mouse turd. And what they found is that not only did the mice live longer and have good physiology changes, but their actual behavioral outcome is better too. You had improved behavior, suggesting the central nervous system is working well. So right now, when we look at the whole issue of dementia, these are the sort of approaches you see out there. The number of companies concentrating on beta amyloid. We see companies focused on tau tangles, or in some cases both, mitochondrial dysfunction, immune inflammation, and so forth. But what we're going to do is take this and attack the entire problem by targeting the fundamental cause, which is cell aging and what the implications are for age-related dementias. Now, our approach is to restore normal function to aging cells. We're actually going to reset cell function in microglia and cells, or glial cells and neurons within the brain. And we're going to do this with our first intervention being telomerase therapy, using human telomerase gene, a normal gene, targeting Alzheimer's initially, but then moving on to the other age-related dementias and other age-related diseases. Our primary concerns are not only the obvious ones of safety and efficacy, which matter to us enormously, but credibility. As I've said, we know of more than, depending on how you define these, 1,100 interventional trials for Alzheimer's and age-related dementias, which by global consensus have failed to show a change in disease course. So if we can show that we can not only slow and not only stop, but to a degree show reversal of some of the cognitive decline, it would be expected that people would disbelieve this. So we're going to have to be exceedingly careful how we've done this. We have gone out of our way to recruit a scientific advisory board and clinical advisory board of skeptics, people who honestly think that this model is well worth testing and want to see it tested rigorously and credibly, rather than people who are true believers. We think that we can intervene in age-related dementias, but only if we do this exceedingly well and carefully and credibly. And finally, as I said before, it is not a matter of having a model that is consistent with all known clinical data, which this one is, and predictably valid, which this one is, and offering you an innovative and feasible point of intervention. The question is, what does the clinical data show? And we will see. So I'd like to thank you all for joining us, and hopefully you'll enjoy the rest of the seminar. And if you have any questions, please feel free to get back to me, and we'll see what the data shows. Thank you very much.